Visiting Professorship Lecture in Cardiovascular Disease. I don't know if you all know this, but Dr. Lemberg was actually one of the founding members of the medical school back in 1952. And his whole career has been intertwined with that of University of Miami, later University of Miami Miller School of Medicine. We're truly thrilled today to have members of the Lemberg family, specifically Dr. and Mrs. Alan Saltzman, as well as their son Russell, who I work closely with in clinical trials. I treat him like my own son. Except I don't yell at him like I yell at my sons to put away the shoes. Paula, Alan, Russell, thank you so much for joining us and being a part of our family. In 1990, the Miami community honored Dr. Lemberg by establishing a chair in cardiology at the University of Miami Miller School of Medicine. Dr. Lemberg then presented an endowment to the medical school in honor of his wife, which was used to create the annual Miriam Lemberg Visiting Professorship in Cardiovascular Disease, now in its 25th year. So this is a very special year, right? 25, 50, those are always special. I guess that's why we have a special speaker today. So Dr. Lemberg's contributions have left an indelible impact on our school, our community, our cardiology community. Many things we take for granted, such as a demand pacemaker, right? He was instrumental in developing back in the 1960s. And remember, back then, for those of you who are used to your smartphone, there was no smartphone, there was no digital, everything was analog. So everything was very novel. So, but in addition, it was also Miriam Lemberg's drive, an initiative that made the Lemberg Chair possible. We are truly grateful to both of them for their commitment and dedication to advancing the field of cardiology and helping to propel our cardiovascular division in our school to the heights where it is today. Thank you.
It is also my distinct honor to introduce today Dr. Joshua Hare for this talk. Dr. Hare completed his medical degree and residency training from Johns Hopkins University, followed by a fellowship in cardiovascular disease at the Brigham and Women's Hospital. He was professor of medicine at Johns Hopkins University and director of the cardiovascular section of the Johns Hopkins Institute for Cell Engineering for a number of years before he joined the University of Miami. And today, among many other titles, he serves as the Louis Lemberg Professor of Medicine and director of the Stem Cell Institute at the University of Miami Miller School of Medicine. Dr. Hare is truly one of the world-renowned pioneers in the use of stem cell therapy for the treatment of cardiovascular disease. He has an extensive track record of breakthrough translational stem cell research, having authored more than 300 manuscripts in the field, which have received tens of thousands of citations. Dr. Hare has also served on the editorial board of numerous prestigious journals and is the principal investigator on many grants, many of which are NIH funded. Please join me in welcoming Dr. Joshua Hare.
Well, good afternoon, everybody. It truly is a great pleasure to give this 25th Miriam Lemberg lecture. It's been my great honor to hold the Louis Lemberg chair. It's also been a great privilege to work with you all here, and I'm especially grateful to the Saltzman family for all of their support, in particular lending us their son. So I thought it would be fun to try to give a 10-year update of some of the work that we've done here. So I have a lot to try to cover, but I'm going to try to keep it thematic. And one of the key things that I want to do this afternoon is thank a lot of people, and I have a lot of pictures of people. I'm going to start with a disclaimer. If I don't mention your name, I apologize in advance. But I really want to thank everybody I've had the privilege to work with, particularly each and every member of the cardiovascular division. I'll start with my obligatory disclosures. And so what I'm going to talk about is the quest for successful cell therapy. I think this is a very exciting story to tell. I think it's a little bit reminiscent of what it must have been like to work in percutaneous revascularization in the 60s and 70s, where we were experimenting with thrombolytic therapy and then angioplasty, and didn't quite have it right, didn't get it right until a decade or so later. There was a lot of controversy. There was a lot of skepticism. Would it ever work? But as we all know, as we know historically, when we persevere, we are capable of doing amazing things in medicine, and the last century speaks to that. So I would submit to you that this is the next great, big, important thing in cardiovascular medicine and in many other areas. And what we've had the great privilege here to all work together to make some very instrumental observations. I'm going to take you through those observations in a series of clinical trials that we've conducted. I'm then going to come back to show a few slides about basic science and then conclude. We have been very fortunate to be funded extensively by the NIH and other foundations, and have conducted a large number of clinical trials that have really been proof of principle trials that have allowed us to document in humans the mechanisms and manifestations of this new therapeutic strategy. So these are this is the current team of the clinical coordinators and regulatory who oversee all of the clinical trials, and I'll just start by thanking them. You'll see Russell Saltzman right there. So one day we'll let him come home for dinner, because we keep him chained to his desk. Our main focus has been on a cell type called a mesenchymal stem cell. This is an adult stem cell that can be culture expanded from bone marrow, and we've had a great deal of success with it. It's easily obtained, it can be expanded, and it can be used as an allograft, and I'll come back to that. That's particularly important for developing this as a biopharmaceutical, because it can be mass-produced. In a large number of studies that we've had the opportunity to do, and others elsewhere, we've shown that when injected into a healed myocardial infarction scar, these cells prevent and reverse remodeling of the ventricle. They do so by engrafting, differentiating to a limited degree, but importantly stimulating endogenous cell repair mechanisms. And I'll show you about this. This becomes very important because understanding this has led to the next generation of therapies. We've shown that it's safe in humans, and we've done the clinical trials that I'm about to tell you about, in which we've enrolled about 300 patients and have in particular shown the safety features. Now, this is probably the most important thing I want to say. There are 4 mechanisms of action. We've shown that these mechanisms of action operate in humans, and that's why I call the trials that we've done proof of concept. And this is, understanding this has allowed the field to drive forward. So the cells are antifibrotic. They reduce scar tissue, particularly a myocardial infarction. They do this very importantly in other tissues. I just sat with Dilip Yavagal yesterday from neurology, who showed me his beautiful data of how this works in the brain as well in individuals who've had a stroke. They stimulate neovascularization. They are anti-inflammatory, and they stimulate endogenous repair mechanisms, going back to this issue. And it's the stimulation of endogenous repair mechanisms, as I've said, that I think is the next generation insight to the field. The first trial we had the fortune to do was called the Prometheus trial. If you know the story of Prometheus, he stole fire from Zeus. His punishment was to be chained to a rock. Every night an eagle came and ate his liver, and each night that regenerated. So the story of Prometheus has come to be associated with regenerative medicine. Interestingly, in 20% of the stories, the eagle is eating his heart, not his liver. And this picture depicts the eagle biting away at his thorax, not his abdomen. We took that and started a trial funded by the NIH called the Prospective Trial of Mesenchymal Stem Cell Therapy in Patients Undergoing Surgery. So we borrowed the name. And this was the very first trial that we started here in 2008, immediately after the Stem Cell Institute was formed. This trial was very important because it allowed us to do a very detailed phenotypic evaluation of the response to the cells. because we were injecting the cells in the operating room, we could document exactly where we were doing the injections, and we created a map of the left ventricle of each patient, as shown here. Dr. C. Pham, who was the surgeon who did this, actually drew the little dots on the heart, and we were able to very carefully track where we had injected the cells. And then we used cardiac MRI to look at the phenotype. This was very important because cardiac MRI is a very powerful imaging tool. You can look at cardiac function in a variety of ways. You can look at tissue perfusion, and you can look at scar reduction. So you can look at the mechanism of action of the cell therapy, and you can relate it exactly to the location on the heart where we knew we had injected the cells in the operating room. And this led us to do a very beautiful study that was led by Vasilius, who is presently a house officer here on the Jackson House staff. He's here in the audience. And he did a very beautiful analysis where he showed what we called a concordance score. He showed that by using the MRI, he was able to show that where we injected the cells had the greatest concordance of events: neovascularization, scar reduction, and restoration of function. And a score of 3 is the highest score. And indeed, in the area where the mesenchymal stem cells were injected, you had this concordance. This could be seen in this high-resolution MRI scan. This shows a patient before and 18 months later, and the scar is encoded in red. And you can see the huge extent of the scar, and 18 months later how it's shrunk both in circumferential extent as well as in total mass. And this was published in Circulation Research. You can go and see more details. But this was mechanistic proof that the 3 issues that we had alluded to in the animal studies, which I haven't shown you, were operative in humans. We then went on to further study this in a study called the Poseidon study. And this is Poseidon with his trident fork, and we've used that in a subsequent study that we're now doing called the Trident study. In the Poseidon study, we wanted to start to look at percutaneous delivery of the cells and to compare allogeneic versus autologous cells. Again, as I mentioned before, if you can use allogeneic cells, you can mass produce the cells and then develop an actual biological product. This, too, was funded by the NIH through the Specialized Center for Cell Therapy Network. And we had a wonderful innovation in this trial. We used CAT scanning to look at scar size. And you could see here in these color-coded images a patient before and after injection. And you could see the very significant reduction in scar size in this individual before and 13 months later using CT imaging. Now, in this trial, we started to see that there were clinical benefits to doing this. This is the 6-minute walk distance, peak VO2. The 6-minute walk distance improved in the patients, and the patients also felt better using a Minnesota Living with Heart Failure questionnaire score. 2 very standard clinical measures in heart failure trials. This was the very first trial to look at this, to look at scar size in this number of patients and these 2 clinical parameters, 6-minute walk distance and Minnesota scores. And what you'll see now in the current studies that are going for FDA approval, they're using these parameters. And we were a very early adopter of these type of metrics for patients. And this is the first demonstration that patients actually feel better and have greater functional capacity with this type of treatment. This trial was also very important. It was the first trial to ever in all of medicine to compare head-to-head the allogeneic versus autologous cells. And I won't spend a lot of time about the immunology, but we know that these mesenchymal stem cells are both immunoprivileged and immunosuppressant, and that means we can give them as an allograft without concurrent immunosuppression, and the Poseidon trial was the first to demonstrate that. That has opened the way for us to do a plethora of other studies right now with these allogeneic mesenchymal stem cells and develop whole programs of work. It also has assisted some of the active biotechnology companies who are doing phase 3 clinical trials with allogeneic products do their work. We then went on to do another trial called the TAC-HEFT trial. Both the Poseidon and the TAC-HEFT used a catheter injection rather than a surgical approach. And in the TAC-HEFT trial, we wanted to compare, this was our first placebo-controlled trial. We compared active mesenchymal stem cells to the bone marrow from which they originated, and patients were randomized to 3 groups here. All of the injections in both of these studies were done by Dr. Alan Heldman, who is also here in the audience, who did just a spectacular job of very safely administering each of these patients. And Alan and I used to fight because he insisted on doing the first 100 to make sure that there was no complications. And indeed, he's absolutely correct. There wasn't a single complication of using this new catheter delivery system in about 100 patients, and we've now done more than 100 patients. So this now is going to the next level of medical and scientific proof, because this is a randomized study. So when we were delivering the material to the patients through the catheter system, we were blinded. The patients were blinded, and all the members of the team were blinded to what the patients were receiving. So this was a prospective randomized study, and we were then able to, once we had all of the data and all of the follow-up was done, look using cardiac MRI, or in some cases CT scanning, at the infarct size and the function of the ventricle. And here, I think, is a very, very important finding. You see examples in this panel. This is the infarct size reduction in the mesenchymal stem cell group. It's about a 30% reduction, which was the same amount in the 2 previous studies, and it was not matched by either the placebo group or the patients receiving whole bone marrow. This was very important because at the time, some people were arguing, well, it really doesn't matter what you inject. Any cell that's injected will have some kind of effect. And this showed that indeed that's not the case. The mesenchymal stem cells were particularly potent at the antifibrotic effect. And scar reduction has now also become a very, very important endpoint in clinical trials. We didn't just do the scar reduction, we also looked at the regional function using a process called tissue tagging, derived from these cine images. And the more negative this number goes, the better. That shows that there's the greater amount of deformation of that ventricle. And what we showed in this analysis is that where the scar is reduced, it's replaced by contractile myocardium. So this speaks to the fact that there are regenerative mechanisms and that there are new cardiac myocytes that are growing that are actually able to contract and restore contraction to those previously damaged segments. We didn't stop there. We have continued to do yet another body of work, turning our attention away from patients who've had a previous myocardial infarction to what we consider in cardiology the second most important cause of heart failure, dilated cardiomyopathy. This is a patient with dilated cardiomyopathy. Those of you who went to medical school here have seen this before, because I always show this slide in my lecture on dilated cardiomyopathy every year. And what you can see is there's no scar, but there's massive enlargement of this ventricle, and it's very rounded. This is a ventricle about twice the size of normal, and this rounded shape is very inefficient for the heart to contract. This accounts for 50% of heart transplant, and this is the leading cause of heart failure in young people, particularly children and teenagers. So this is very important for pediatric cardiologists. But there's no scar. This is a condition that's caused by genetic or immunologic conditions, and we reasoned, again, because of our understanding of mechanism of action, that the anti-inflammatory effects and other effects could promote a reverse remodeling in these patients. So we did a randomized comparison, again using the Poseidon nomenclature, looking at the allogeneic versus autologous cells. Now, we were pretty excited about this going into it because of the immunologic component. We were excited that that component may be very important in these patients. So this was a beautiful analysis of the patients. ejection fraction, again done with a sophisticated imaging. The pictures are of Angela and Vika, who are presently in the lab in charge of what we call our imaging core, and they've done just a gorgeous job of learning how to do this imaging analysis, working with colleagues in radiology, and doing this very exciting analysis, which shows that the ejection fraction goes up about 7 EF units, which is very meaningful. It was greater in the allogeneic patients versus the autologous. And when we looked at it this way, the data this way, we were very, very excited. 40% is the cutoff for the diagnostic criteria, and 50% of the patients in the allogeneic group went above 40%, meaning that they're, by some criteria, actually cured. Here's an example of a very dramatic example. This was a woman with a longstanding adriamycin-induced cardiomyopathy. These patients were eligible. There's a very profound enlargement and left ventricular dysfunction here at baseline, and 12 months later, the function is almost normal at 43%. This is one of those patients who went above 40%. As with the other studies, we see improvement in quality of life scores. This is Minnesota Living with Heart Failure questionnaire, and this shows the improvement in the New York Heart Association classification, the green being improved, and you see that going up very nicely, particularly in the allogeneic. The magnitude of this recovery is much greater than with the ischemic cardiomyopathy, and this has got the community very excited, particularly pediatric cardiologists who immediately want to start doing this in a study involving children. As with the ischemic, there's an improvement in the 6-minute walk distance, as shown here, and also an improvement in pulmonary function. Now, we've had the opportunity to look at some very exciting mechanistic findings. This is the work of Courtney Premier, who's pictured here, who's a very talented PhD student in our laboratory, who actually got her PhD very recently for doing this work, where she looked at endothelial function. This is a mechanistic insight into how neovascularization occurs, and in this slide we show both the change in circulating endothelial precursor cells and the improvement in forearm flow-mediated vasodilation, both improving to a very profound degree in patients getting the allogeneic therapy. We had another very exciting mechanism of action finding. This is the work of Anna Marie Landon, also in the laboratory right now, who did a very wonderful and detailed analysis of immunologic markers and cellular markers of the inflammatory system. Patients with dilated cardiomyopathy have very high levels of TNF-alpha, as shown here, and had very dramatic reductions, about 70% in the allogeneic group versus 50% in the autologous. So we have proof of concept, mechanism of action information from this trial. We were able to conclude from the study that the allomesenchymal stem cells improved the ejection fraction, the other parameters that we talked about. We concluded that immunomodulation may contribute to this mechanism of action, and that future studies should be done, which we hope to have the opportunity to do. We're very proud that we've been able to publish each of these 4 studies I've shown you, and in each case they've been with a concurrent publication, presentation at the American Heart Association. And if I haven't mentioned your name as a collaborator, you certainly are listed here in very small print. If anybody wants a copy of the manuscript, email Wayne Balkin and he'll send you the papers. But we've had a really nice publication track record, and I think it's this publication track record that really contributes to the field. And as I said, these are things that agencies like the Food and Drug Administration pay attention to when they're making decisions about approving these types of therapies for broader use. We didn't want to exclude our colleagues in electrophysiology out of making their contribution to this, and this is a beautiful paper that just appeared on March the 2nd. This was led by Raul Mutrani, and the first author was Archie Ramareddy, another Jackson House officer. And what they did was they looked at an analysis of various parameters of the propensity for proarrhythmia, and showed that in the mesenchymal stem cell group, but not the other groups, that the greater the reduction in scar size, the greater the reduction in ventricular ectopy. And there were other measures in this beautiful paper showing how cell therapy might actually be anti-arrhythmic, which is very important in the field, because in the early days of this field, there were concerns that cell therapy may be pro-arrhythmic. And actually, some early studies insisted that patients get defibrillators. So that is the proof of concept work that I wanted to share with you from the clinical trials team that we've been able to do. But I do want to spend a little bit of time talking about what we're able to do in parallel in the laboratory. And this is a recent picture of the laboratory, the basic science folks. And I want to talk about the crucial role that basic science has played in guiding the translational development of our therapy. About 10 years ago, as we were getting these exciting results that scar was being reduced and function was being restored, it was very controversial to understand how that was occurring because the cells weren't sticking around long. And so many argued that, well, if the cells you're injecting aren't differentiating into cardiomyocytes, how could that be important? Well, another very talented member of the team, Kostas Katsagourgas, who is about to join the faculty, who has been working relentlessly on this problem, showed in 2010 in a paper in Circulation Research 2 mechanisms of action by which this could occur. And those are proliferation of stem cells, endogenous stem cells, and this was a key panel from his work, which was published in Circulation Research. The red cells are endogenous precursor cells, and these cells greatly proliferated after we injected the mesenchymal stem cells and actually engaged in cell-cell interactions with the injected cells. This injected cell is stained with green. There's an endogenous cell in red, and they're bound together by connexin 43, which is the protein that mediates gap junction. So this forms the basis for a cell-cell communication between these two cell types. In addition to that, there was an upregulation of mitotic activity in adult cardiomyocytes, as shown here. You see the phospho-H3 staining signifying cells in the cell cycle. So this was the first demonstration of a stimulation of endogenous repair. So there's a secondary effect. We give our cells, and they create a secondary effect that appears to have a very long-lasting effect. Kostas didn't stop in 2010 working on this. This has become very, very controversial, and he's developed a beautiful model in mice where the endogenous cells, the c-kit cells, are endogenously labeled. Now, don't get confused from the previous slide. The green cells here are the endogenous cells, not the mesenchymal stem cells. And he took a piece of heart tissue here, and he cultured it on a lawn of mesenchymal stem cells, and he could show an upregulation and proliferation of these mesenchymal stem cells as well as a migration. And this was just published in the fall in Circulation Research, and this image is actually on the cover of the journal, so we're very proud of that accomplishment. We've done a lot of other work over the years. This is some work that Christina Sanina did. She's now left the laboratory and is a house officer in New York. And she did some beautiful experiments. I thought I'd just show you these higher magnification images showing that in vitro you can get these cells to interact. So these are neonatal rat cardiomyocytes. These are mesenchymal stem cells in green. And you can see how they bind to each other by connexin 43. So this cell-cell interaction is a very, very important interaction. So this led us to formulate a hypothesis that if we mix these two cell types together, we can augment the effects of the cell therapy because these two cell types clearly work together. And so we have engaged in a program of work. We've now published 3 or 4 papers. This was the first in Circulation in 2012. This was the work of this very talented investigator, Adam Williams, who's now a cardiac surgical faculty member at Duke. He was a surgical resident who came to the laboratory. He did this amazing work He won the Vivian Thomas Prize at the American Heart Association for this work. And the bottom line is we culture expanded the mesenchymal stem cells and the c-kit cells. We mixed them together. We injected them into porcine hearts, and we showed that the mixture was twice as effective as either cell alone. I want to just special shout out to two very key members of the laboratory who've been with me since I started it here, Wayne Balkin and Irene Margetich. I think they're both here. And they're the team leaders that have really marshaled all of this work and kept it going for decades. So thank you, Wayne and Irene. The mixture hypothesis of mixing these two cells together has made its way all the way to the National Institutes of Health into a multi-center trial that's chaired by Roberto Boli from Louisville called the Concert CHF trial. And you can read the title there. I won't read it out in the interest of time, but it basically takes the hypothesis that was born by Costas's work in the laboratory in 2010, through Adam's work, through other work, now to an NIH trial. And this is the sample size and treatment group assignments, and you see just like in the pigs, we have the four groups: combination, mesenchymal stem cells, cardiac stem cells, and placebo. We have a phone call every Wednesday morning about this, and I believe that we're up to 17 or 18 patients enrolled, and the enrollment is very brisk, and it's going very well. So in a year or two, we'll have the answer as to whether or not this combination has improved effects in humans. These are the different centers as listed here. At University of Miami, we are not only an enrolling site, but also the site of cell production, which I now want to come to next. And I want a special shout out to Dr. Matrani and Yvonne Schulman, who are key leaders in the CCTRN project and in many other projects that we've done in the clinical trial arena over the years. Dr. Matrani, I believe, is now going to be testing the cell therapy as an antiarrhythmic approach in an animal model with support he's just received from the Florida Institute of Heart Research. So we're very excited about that. And Dr. Schulman's just received her R01 to look at some of the features of endothelial dysfunction in patients with diabetes undergoing cardiac procedures. So the cell lab, we've had very fortunate to have many components at the Cell Institute. I've shown you about the basic science lab, the clinical team. We have a very wonderful GMP team. The team is led by Aisha Khan, pictured here, who's also in the audience. And Aisha and her team have done just an amazing job at culture expanding these very complicated products, not just for our cardiac work, but for many, many other programs around the university. And I believe we're manufacturing 7 to 10 different types of products. And every time I bump into her in the hallway, she tells me about a new thing she's culturing or a new technique. This is the standard technique for culturing mesenchymal stem cells, and I won't go through this in detail. There are multiple publications about this, but what I do want to show you that we're very proud of is the work that we've done in the laboratory to culture expand c-kit cells, which is a critical element to being able to do the Concert CHF trial. So Aisha and her team have advanced this technique and got an FDA approval to take a heart biopsy from a human, digest it, culture it up, get a culture of cells, and run those cells over a column to obtain the c-kit cells and then further expand those cells. And here are some growth curves. We're able to do very wonderful expansion and get target ranges. Here are 5 examples of these c-kit cells being expanded. And here is the characterization of these cells showing that even after culture expansion, we're able to have a high 90% c-kit positivity on the cell. So this is critical because we can now reduce to practice this idea of mixing the c-kit cells with the mesenchymal stem cells and using them as a therapeutic. And I hope I'll be back in a few years to give you the results of the Concert CHF trial. Just in the last few minutes, I wanted to show you a few other very exciting things about this field. Now that some of the controversy has died down and there's more acceptance that these trials can and should be done, we start to see the really elegant application of this cell therapy to other situations of high need. This diagram depicts the three staged operations that children with a terrible congenital condition called hypoplastic left heart syndrome have to go through. These children are born without a functioning left ventricle and a diminutive aorta, which means they are not getting any blood flow to their body. And up until 30 years ago, this was a uniformly lethal condition until a surgeon named Norwood developed this operation, I believe, at the Children's Hospital of Philadelphia, where he reconstructed the aorta with a patch and did some other very fancy anatomic reconfiguring, whereby the aorta now pumped the blood from the right ventricle. The children only have a right ventricle, so the blood flow from the right ventricle is shunted to the aorta, which has to be reconstructed because it's diminutive, and then this way the life of these children can be saved, and they can have blood perfusing their body. They require two additional other operations to reconfigure the flow of blood so that there's venous return to the right side, and the right side pumps the blood out. And you can see there's a variety of reconfiguration that occurs. This operation is done at 4 months of life and then at 3 to 4 years of life. Now, with these three operations, the survival of these children is about 50%. So it went from 0 to 50, but 50% of these kids are still dying, and guess what they're dying from? Heart failure, because that right ventricle is insufficient to fulfill the needs as a left ventricle for their entire life. And thus comes the hypothesis that we can add a fourth step to these three operations, which would be cell therapy. And this CT reconstruction is a CT of a 4-month-old having the second stage operation of their reconfiguration for hypoplastic left heart. This is done in collaboration with Sanjay Kushal at the University of Maryland, and these are the 8 injection sites in the right ventricle of this child at the second operation, and we'll be following these children to see if the cell therapy can reduce the need for heart transplantation and reduce the death rate. And guess what? What became instrumental when we were talking to the Food and Drug Administration about wishing to do this? It was the work we had done earlier in the Prometheus study, where we had carefully done these injections in adults, and that became very important to the Food and Drug Administration, and we're now doing it in children. A couple of other things I'd like to mention. Our areas of interest have broadened greatly. Today is the Lemberg Lecture, and we're talking about cardiology, so I'm not going to talk about this in much greater detail other than to mention that a lot of the lessons we've learned from the cardiac field have been expanded into other areas, one of which is very exciting is the issue of aging frailty, which in many ways is a heart failure-like syndrome characterized by systemic inflammation. And we've done a series of experiments in patients where we've infused allogeneic mesenchymal stem cells into older individuals with frailty. Now, as I mentioned, part of that comes from the work we had done in clinical trials, and this was an analysis, a retrospective analysis that Sami Gulpanian did, who was a surgical fellow in our group following Adam Williams, and he looked at our database of patients below 60 and above 60 and addressed what was a very controversial hypothesis at the time, that older individuals might not respond to the therapy the way younger did. But lo and behold, in this paper published in the Journal of American College of Cardiology, we were able to show that the older individuals perform just as well as the younger individuals. So we have, that is the whirlwind tour of our work and our thinking. I think we've made some key contributions where we show that mesenchymal cell therapy reduces scar size, reperfuses scar myocardium, and restores contraction. Very importantly, I've shown this in a number of times. We restore contraction to the area of akinesis due to previous myocardial infarction. We've shown that mesenchymal stem cells can be safely used as an allograft in cardiac patients and safely injected, as Dr. Heldman has shown and taught many of us how to do. Very importantly is the finding that mesenchymal stem cells stimulate endogenous cardiac repair mechanisms, a finding that we have published and have been able to deploy in a new trial that will test that by using this combination cell therapy approach. So where is the field in 2017? Well, we are in phase 3 trials. There is a large multi-center trial at 50 sites, the DREAM-HF trial, being sponsored by a company called Mesoblast that we have no interest in. They're an independent Australian company. We are a site in this trial, but the DREAM-HF trial will enroll over 600 patients in a phase 3 trial using a cell type that's similar but slightly different from the one that we've been using, and it's called the mesenchymal precursor cell. If this trial is successful, we could see approval of this approach sometime in the next 3 years, hopefully by the end of the decade, thereby allowing this therapy to proliferate and be able to be used more broadly in the way angioplasty proliferated in the late 70s, early 80s. The other big thing that's happening is that the CONCERT-HF trial, which is based on our work here, is enrolling through the NIH study, and this trial tests our concept that cell-cell interactions are very important. So mesenchymal stem therapy is now being tested for diverse cardiac conditions, hypoplastic left heart, Adriamycin cardiomyopathy, and through Yvonne Schulman's R01 for cardiac coronary artery disease in diabetics. Just want to show you how our team has evolved over the years. This was the team in 2011. Many very important contributors are pictured here who've gone on to other great things, and many people are still here. I particularly want to mention Dr. Jim Symes, who was the head of cardiac surgery at the VA, who has unfortunately passed away. Dr. Heldman is here, Dr. Williams is at Duke, and Dr. Ian McNeice is still working in the field as well. This is the team today, all together, and I really want to thank each and every one of you. It's been my great honor and privilege to work with you, and I hope we will continue to do great things for the next decade. These are our funding sources, many sources from the NIH and several foundations, and I want to end by a picture of Lou and Miriam. Some may think that they're sitting here talking about the upcoming Lemberg lecture or naming the chair, but I think they're having a much better time and are not thinking about cardiology right now, but maybe other matters of the heart. Thank you very much. It's been my honor to give this lecture.
Great. Josh, 10 years in science is a very short period of time, but you have accomplished, and your colleagues, a tremendous amount. And the University of Miami is proud of you, and we all are, for all your accomplishments. Let me begin by asking a simple question. Ideally, at some point, we would like to use, I would imagine, cell-free extracts that would do the same sort of thing in terms of stimulating endogenous cells to whatever it is that stimulates them when they touch the injected mesenchymal stem cells. How close are we to understanding what the chemistry is there and what the mechanism is so that we can sort of bottle that and inject it?
Thanks, Roy. That's a great question, and that's a very important hypothesis. Can we identify what the active ingredient is? And there are many candidates. Some is the cell membrane. Some is a particle called an exosome that's released by cells that contains microRNAs. However, what I would argue is that maybe the cell is going to be better. Maybe the next generation of biologics is the living cell. We transitioned from chemicals to proteins made in a recombinant system in the laboratory. And now I think it's attractive to speculate that maybe the cell itself could be the unit of activity. And one thing that's particularly attractive about the use of cell therapy is that It has information. It has information and can track itself throughout the body, and it has this very long-lasting effect. So what I would say is that once we have a lead candidate of a cell-free extract, I think it would be important to do head-to-head comparisons. Just the way we compared an angioplasty balloon to a stent and a stent to a coated stent. At the end of the day, these things can only be borne out in rigorous clinical trials.
Great, thank you. Any other questions? Well, being none, you left us all speechless. Except me. Dr. Mitrani has the presentation.
Thank you.
Thank you, Josh, for a tour de force on the field of cardiac stem cells. It is my honor and pleasure to present to you this plaque, the 25th Annual Miriam Limburg Professorship in Cardiovascular Disease. Dr. Hare, I know you have lots of plaques. This should be the first of all the plaques.
Maybe the family can come up and take some pictures and the rest of you are excused. Thank you.
By the way, it was my daughter's wedding this Sunday, so this is my
Thank you very much. Thank you. Thank you.